60-year-old male patient presented with a recent acute coronary syndrome. Echo showed LVA 46%, inferoposteroval hypokinetic. ECG had a atrial fibrillation, STT changes in the inferior leads. Now, angiography showed a multivessel coronary artery disease. RCA had a CTO. There were lesions in LAD and LCX. So, plan was first we will attempt the CTO in RCA and a staged PCI to LAD and LCX later on. So, this was the angio where the LCX lesion can be seen. There is also a LAD lesion in the mid part, and the RCA we have a CTO from the distal part. So, after gradually using the upgrading the wires from intermediate to Gaia, by tactile sensation the wire went very smoothly, and we thought we had, in overzealously, we thought that we had crossed the lesion very well and the wire is in place. But soon we realized the wire went through a smaller branch and there was a major perforation. On contralateral dye injection, we can see that the wire had gone through a smaller branch and caused a perforation. And we immediately blocked the leakage area by inflating a NC balloon at high pressure. For the cardiac tamponade, we had to do a urgent pericardiocentesis. Now, what we did was, with the help of a microcatheter, we tried to enter the true lumen. We recrossed using the microcatheter, we used a whisper guide wire and we wired back into the main lumen. Pericardiocentesis was done, patient was stabilized. So one option was to use another wire, put in another wire in the true lumen, and while we are inflating one NC balloon proximally, we do a serial dilatation with the other one. However, in the risk of wire coming out of the balloon not going in, we did quick pre-dilatation in the disease segment of the RCA, sequentially with 1.25 and then 2.5 balloons. After that, we put a cover stent at the origin of the perforated branch, and then we put another stent in the proximal RCA. So this was our initial result. So the perforation has been sealed. More or less the distal RCA has been rescued. We can see we had managed to cross the wire in the PDA. The PLB branch is somehow, the flow is not seen, but the patient has become stabilized after the pericardiocentesis, the vitals are stable, no chest pain. So we left like that, and later 2 weeks, after 20 days, we took the patient for stenting of the LAD and the LCX, and there we checked the RCA first. The RCA was doing reasonably well, patient had no chest pain, so we left it like this. So careful vigilance and preparedness for any complication like coronary perforation or tamponade during any CTO case. And during CTO case, we should not be over happy with our own tactile sensation that the wire is going smoothly. Covered stent, coil, particles, abgel, etc. must be kept in the cath lab wherever we are attempting any complex PCI. And also the confidence of a cardiothoracic surgery backup, like if any complication happens, then that needs to be there. An emergency pericardiocentesis during such cardiac tamponade can be life-saving, and we can get some time to complete the rest of the procedure. Thank you.